We have another special guest here. She is the president and co-founder of Patients Out of Time and the president and founding member of the American Cannabis Nurses Association. So please welcome, ladies and gentlemen, Lynn Mathre.
Aloha. I am very glad to be here, coming from Virginia where they just got nailed with snow, so it's really nice to be here. I just want to start out with some statistics. Did you know 2 million adverse drug reactions every year, and more than 100,000 people die in the hospital just from adverse drug reactions. And every day we lose 44 people from overdose of prescription medications. And I apologize, the slides are a little faint here, but in 2014, more than 47,000 Americans died from a drug overdose, and opioids were in 60% of them. My name is Lynn Mathre. I'm a registered nurse of more than 40 years. I'm a Navy veteran, so the veterans issues is huge for me. I'm married to a Vietnam vet. I was a Vietnam era nurse. Then I want to talk to you about the remarkable safety of cannabis. For the past 14 years, nurses have been ranked the most trusted professionals. So I think we kind of earned that just by the virtue of the fact that we spend the most time with patients. We provide nursing care, we educate about medications, we monitor the effects of treatments and medications. And unfortunately, most of our time in the clinical setting is set around medications, medicating or running around trying to take care of the side effects of the medications we give. As a nurse, we get things drilled into our head. We soon learn we can kill people real easily. We have to know that we've got the right drug, in the right dose, at the right time, by the right route, to the right patient. And when you're dealing with thousands of medications and 20, 30, 40 patients at a time, that's a really scary thing. We get our heart pounding when we think, oh my God, did I just give this to the wrong person? So this is very important. Don't fool yourselves. So the main thing for anyone that nurses want to know is any medication can kill you. It's up to you to know the risks and the benefits before you take something. Don't just take a pill because somebody says, here, it's going to help. And just as Michelle said, it gets very complicated. They give a drug, they try to medicate another symptom, they give another drug, and before you know it, you've got a pharmacological soup stewing in your body. I think many people have grown up with the marijuana, gateway drug, a motivational syndrome, leads to murder and rape. That was the reefer madness from way back when, that it destroys brain cells. And the fact that it is in Schedule 1, that's a forbidden drug category. Physicians cannot prescribe for that. The point is, cannabis is and was an old medicine. You can see them a little on the left side there. Those are Eli Lilly bottles, labels from that. Tincture of cannabis, they had cannabis pills. Dysmanine was for menstrual cramps for women back in the day. It worked excellent. And they had corn plasters, they had topical cannabis products. And yes, they even smoked it. Cannabis for asthma, cigarettes to help people with asthma. Back in 1985, I went back to nursing school. I was out of the Navy. I went back to get my master's degree, and I did my thesis on marijuana disclosure to healthcare professionals. At the time, marijuana was the most used illicit substance, and I thought, well, aren't we asking patients about their use? And if we asked, would they admit to use? So I did a whole survey. The last question I just asked, do you have any health concerns? And I listed the possible things that they could check off, and they could check off more than one if they wanted to. But 25 people checked other. And of those, they said, I use it for migraines. I use it for migraine headaches, nausea and vomiting. I'm a spinal cord injury patient. I use it for spasticity. I have multiple sclerosis. It helps me. This was like, wow. I didn't know that. I knew marijuana, drug of abuse. That's all I knew. How could I not know that this was helpful? Well, we go back to reefer madness back in the 1930s that started it all. If you haven't seen the movie Reefer Madness, it was a college hit back when I went to school in the 70s and 80s. It is so ridiculous, you can't believe it was true. But you try cannabis and next you know you're either going insane or you will commit murder. It was just ridiculous. But we've grown up with that. From that, we developed the Controlled Substances Act. Here's another thing that doesn't make sense. Cannabis is put in the forbidden drug category along with peyote, MDMA, heroin. But along the way, back in 1985, they fast-tracked a drug, synthetic, pure THC, the cannabinoid in cannabis that causes the high. When the government says we're going stronger and stronger marijuana today, and they say, oh, it might be 20% THC. Okay. Oh, we're supposed to be scared of that. They made this pill Marinol, dronabinol. It's THC. It's pure THC and sesame oil. And after several years of being on the market, that was in 85, by 1990 they lowered it. It's the only drug they ever down-regulated. We find these synthetic drugs and we put them into the forbidden category, but rarely do we lower them. Well, there was no diversion, so they lowered this to a Schedule 3. Physicians can write a recommendation for it any time, but they can't use the natural plant. So if we talk about drugs, just need to talk a little bit, when I compare that, back in 1988, it was a long battle, over 20-year battle of trying to reschedule cannabis. The DEA's own judge, their administrative law judge, saw all that evidence, and he wrote that it should be on Schedule 1. It doesn't belong there. And he said, marijuana in its natural form is one of the safest therapeutic substances known to man. I mean, here's a judge, but he can look, he can understand the science. That's amazing. I mean, this is safer than aspirin. I want to talk a little bit about the two organizations. Patients Out of Time, our old logo there, I don't know if you can see it, but it was the marijuana leaf, the wheelchair, and the 11th hour, the clock at the 11th hour. We understood at that time that patients need it now. We don't need more research on its safety, and I'll talk about that in a little bit. We need research on how to dose properly, how to use it, how to use the cannabis most effectively for each individual, because it does vary. But in the meantime, it is safe. Anyone should be able to grow this plant, use this plant. We've moved up to, last year we celebrated our 20th anniversary, so we just updated the logo a bit. When we do our conferences, Patients Out of Time, we bring around, since 2000 we've been doing conferences, we bring leaders from around the world to talk about the latest science. And I don't have time to talk about it today, but one of the key aspects of our talk is about the endocannabinoid system. And if you haven't heard it, please look that up. Endogenous, within our body, cannabinoid system. We have receptors. They first found them in our brain. They later found them primarily in our immune system, but we know now we have this molecular signaling system. We have receptors for cannabinoids. We make cannabinoids. We make our own endogenous cannabinoids, and they fit in these receptors. This system, its whole purpose is to keep us in balance, to help us attain, maintain, and regain health. Vital for quality of life. You need to nourish the system. Whether we juice the cannabis leaf, or if we get hurt and we need help, we take the cannabis in some other form, we are feeding our system. Just like you give insulin to a diabetic, you give Synthroid to someone whose thyroid isn't working well, you have vitamin deficiencies, you give them vitamins. We can supplement the system with cannabis and the cannabinoids in that plant. So as our conferences continued, a group of nurses recognized this. We recognized how important this system is. It is still not taught in medical school or nursing school. And the first cannabinoids were discovered in our brain, the CB1 receptors, in 1988. We found out we make cannabinoids in 1992. By 1995, we recognized this whole system within our body. It's still not taught. So your practicing physicians and healthcare providers, most of them have never heard of this system. So all they know is marijuana. They don't know cannabis and how important it is. But we formed the American Cannabis Nurses Association. If you know any nurses, please tell them about us. We will get them on the right path. Once they learn, they love it. So I want to talk a little bit about drugs. You know, we say we're a drug-free nation. Bull. We've got short-acting, long-acting, sustained release. We got pills, we got salves, we've got, topicals, we've got eye drops, we've got infusions, we've got injections. We got pills for anything and everything. In 2000, 2.8 billion prescriptions were filled. I don't know how many were written, but were filled. And of that, that means about 10 prescriptions for every citizen in the United States. And as you just heard Michelle, she was on like close to 30 medications at one time. That's not conducive to life. That means 7 out of 10 Americans are on a prescription medication, and that doesn't count any of us taking an over-the-counter drug whenever we feel like it. Going into a gas station, a drugstore, a grocery store, pick up an over-the-counter med and pop it whenever you have some kind of discomfort. So, I don't know if you can see this cartoon, but I just love it. You know, they say drug-free America, and this is it. We don't think anything about popping an antibiotic for a little kid, giving Ritalin to those kids who are just a little too active to sit in a classroom for 8 hours a day or something. The appetite suppressants for kids. But if you look at all of this, cannabis could easily replace them and keep everyone much healthier. I think one of the other things Michelle said was she said something about losing all that weight. So many of these antidepressants, I mean, we see people within months, they've gained 20 to 40 pounds. And a lot of our obesity is a result of this. So the question is, how do you know the drug's safe? Well, the FDA came about way back when. They had the Pure Food and Drug Act, June 30, 1906. Those pills, the labels I showed you before, they actually were had on their label, guaranteed by the Pure Food and Drug Act, June 30, 1906. It was approved by the early FDA. But just so you understand, today, for a new chemical that comes on the market, something new, a pharmaceutical company made in their chemistry lab, they test it on animals just to see if it's safe enough and the animals don't die. Okay, we can try it. So then they get to go to clinical trials, meaning they get to study with humans. So first, you might see an ad in the paper. They want healthy people to try this drug. Let's just see, if it's safe enough, if you don't die, and what's the normal dose. If they pass that, they go to phase 2 trials. That means people with the disease condition get in on the study, and they test it to see what are the side effects and what would be the best dose. If that works, they go to phase 3 clinical trials. Now they use it for maybe 1 to 4 years. They do more people, and they're trying to look for adverse drug reactions. So when they finish it, a drug company might have done a whole bunch of studies, but they only have to present 2 to the FDA to say, this is safe enough. The FDA, then they apply for application, and if they get approved, it's an approved drug. These drugs go on the market on an average of only 1,500 patient experiences. So you've only had 1,500 people. Now you've probably heard about things in the old days. For the old folks, you remember thalidomide? It was used for morning sickness. And all of a sudden babies were born with severe birth defects. They had to take that off the market. It's back on the market for other uses, but not for pregnant women. Back in, I think, 1997, fen-phen, a weight reduction drug, was on the market. Oh, people started using it. Whoops. Cardiotoxicity, take that off the market. In 2003 or 4, Vioxx for arthritis, one of the biggest sellers. Oops. Heart attack and stroke, take it off the market. So the point here is, it's not foolproof just because it's FDA. And our physicians, unfortunately, just abide by this so strongly. So for you, let me back up. The deal here is, if you get a new drug, look at that package insert. And on the package insert, it's going to tell you why to use it, what to use it for, how to use it. But it's going to tell you, watch out for the side effects. There are these possible adverse reactions and cautions. It might be, don't take it if you're pregnant, don't take it if you've got kidney problems, don't take it if you've got renal. It goes on and on, a whole bunch of small print. Watch your magazines. You see that nice picture, how this drug is going to fix that indigestion, or it's going to take away your pain, or whatever it's going to do. Don't just look at the picture, read the small print. And then the TV ads. I think a lot of people put the mute on. They're showing you a pretty picture. Somebody's kayaking on the lake. They're having dinner with friends. They're out there working in the garden because they got these pills and it's working. But if you listen while they're playing that pretty music, you hear all of these potential side effects. Many of them, and all antidepressants, carry what we call a black box warning. And that means beware, serious adverse consequences. It could cause renal failure, your kidneys shutting down. It could cause liver failure, your liver not working anymore. It could cause heart attacks. It could cause suicidal or homicidal ideation. So that brings me to just a typical example. As a veteran, these issues are strong, very, I can't focus on the vets because it is too hard to focus, but this is a low number. 22 suicides a day by veterans, and the VA admits it. We think it's double that. And I thought it was because of post-traumatic stress and traumatic brain injury and the difficulty coping. Most of those deaths are the result of these prescriptions. It's the result of what we call polypharmacy. Remember, 2.8 billion prescriptions filled, more than 10 prescriptions for every person in the United States. Some people are getting a boatload of drugs. When you have 4 or more medications at a time, the chance of a serious adverse reaction exponentially increases. So we're just medicating the symptoms of other drugs as we go along. And the veterans are just, and so when you get a veteran, that's the example. They have post-traumatic stress, they might have TBI, they might have an injury. We're going to medicate them for depression. We're going to give them something for anxiety. We're going to give them something because they can't sleep at night because of the nightmares. They're hurting a great deal. We give them something for pain. And it goes on. So, they want to use cannabis. A lot of you want to use cannabis. There is no recorded death. Now, this is since ancient times. So we can look at cannabis and say it's been tried by billions and billions of people over centuries. No death. Aspirin causes deaths every year. Tylenol causes deaths every year. No deaths. The LD50, or the lethal dose of 50% of the animals, is 20 to 40,000 times a normal dose, or consume 1,500 pounds in 15 minutes. If you can, you might die. They just haven't seen it. Death. The Institute of Medicine actually did a full study on this in 1999. They finished their study, 18 months of looking at all the literature, and they basically came back with it should be available for use. They want more research. You shouldn't smoke it. But if you've got cancer or AIDS, that's irrelevant. Any physician should be able to do an N of 1 study. If this medication doesn't work on my patient, I should be able to do it. The government ignored it. They also said, except for the harms associated with smoking, it's no worse than any other med we use. But our government ignored them. They wanted it, they ignored them. Side effects. Patients do get dry mouths. You might get red eyes. That was the telltale thing. Look at those red eyes for those stoners. You might get an increased appetite. Not bad for a cancer patient. You might get an increased heart rate. Usually kind of like going upstairs. If you've got a heart condition, maybe you've got to be cautious. But it's not something that terrible, and generally you get used to it soon. And it might give you euphoria, a sense of joy or well-being. You know, most patients can use that side effect. It's a welcome side effect. I want to talk about the fear that everybody seems to have, addiction. My background is med-surg nursing, but since 1985 I specialize in substance abuse. I'm an addictions consult nurse. We don't call it a gateway drug. What we found is cannabis is an exit drug from addiction. And one of my old bottles of Eli Lilly, I've got a 1915 bottle of cannabis tincture. On the label, it was used for alcohol withdrawal, for delirium tremens, to help calm the person down. It was used for those habits of chloral hydrate and morphine to get the patients off. They knew about it back then. But anyway, so if you want to look, I'm just to help you understand, when you talk about addiction, we're talking about, there is a difference. Dependence, any drug, like any pain medication, if you use it regularly, you will be dependent on it. You will, if you stop using it, you will suffer withdrawal. Just like a benzodiazepine, a barbiturate, an opiate, your body gets used to it. If you just stop, you will go through withdrawal. That's physical dependence. Addiction, you might be physically dependent, but it's continued use despite problems. We all know the alcoholic. You know, they can't function in their work, but they keep doing the job. They get it, drive behind an automobile, causing accidents. They keep using the alcohol. Tolerance is something that happens the more you use a drug, you need more. Again, opiates are a good example of this. When you start something for pain and you've got long-term pain, over time you keep needing a higher dose to get the same effect. The higher dose, the more side effects come with that. And again, physical dependence, the point here is it's just saying that it's going to happen. And if you abruptly stop a drug, you will get problems. This is a longer definition of addiction, and it's just kind of, again, explaining that it takes over your life. You're going to be craving it. You know, your life you spend your time trying to find that drug, to keep that drug no matter the fact that it's hurting you. Pseudo-addiction we see in the hospital a lot. They're not medicating a patient okay for pain. So the patient is, I need my pain medication. They're on the call bell. I need it now. And the doc say, oh, they're clock watching. You know, it's 4 o'clock. It's time for my next pill. Well, it's because they hurt. And as soon as you actually take care of their pain, that behavior goes away. But I took care of many patients in the hospital, and that was the issue. They couldn't medicate properly, and they kept blaming the patient. So, along the way, the DSM-5, it's the Diagnostic and Statistical Manual for Mental Disorders. This is what everyone uses for your psychiatric diagnoses and addiction. And they changed the terms just recently. They now call it substance use disorder. And you'll have specific pages on cannabis use disorder, just like you will for alcohol use disorder. So I want to show you some of this is how you get diagnosed. Depending on the criteria, there's 11 criteria. If you have a mild cannabis use disorder, if you have 2 to 3 possible symptoms that are positive. If you get 5 or 7, you're moderate cannabis use disorder. And if you have 7 or more, you're a serious, you've got a severe disorder. So what are they? Cannabis is often taken in larger amounts over a longer time period than was intended. Okay, that happens to a lot of people. Whoops, sorry. There's a persistent desire or unsuccessful efforts to cut down or control cannabis use. You got to look at what they're doing. Why is somebody using it? Why do they want to cut down? Is it because someone's complaining? Is it because they've got to go for a jump? No? We got it back. Okay. Now get this one. A great deal of time is spent trying to find your drug. Well, if it's illegal and you have to grow it your own, it takes a lot of time. The craving is generally not that bad. But how about a recurrent cannabis use resulting in failure to fulfill major obligations at work, school, or home? And then they get into social problems. Well, when you're growing or trying to get it, you can't have neighbors over for fun anytime. They can't know about your grow. You got to be careful when you open the door. Who's there? Who's coming in? I'm sorry, you can't come in. Is there something on the table that they might see? Have you been using it in the house? So the problem with these diagnoses, the criteria is they're not separating the prohibition of cannabis from the cannabis use. You finally get some of these last ones. Again, persistent problem. And they say, remember, some of the withdrawal might be depression or a decreased appetite. Well, if you were depressed and you tried all these medications, they didn't work, you find out cannabis helps you, and then they make you stop using your medicine, yeah, you might feel depressed again. If you couldn't eat, you had some kind of eating disorder, and this finally gave you the appetite, took care of the nausea and vomiting, and then they took that medication away from you, you might get nauseated again. So it's not separating this. 10 and 11 are two curious ones, tolerance and dependence, withdrawal. The tolerance, very slow to whole cannabis. You'll develop tolerance to the marinol, the THC, much sooner than you will to cannabis. We have federal patients who have gotten cannabis from the government. They're on our board of directors for Patients at a Time. Herbert Rosenfeld, 33 years now. He gets a tin of marijuana cigarettes from the government. He's been using the same dose for 33 years. Bob Randall, the first patient to get in this study, he's dead now, but he had glaucoma, 10 cigarettes a day. One time, he ran out early. What happened? This is strange. They went and they found out the government took their 1 ounce, or their little 1 gram cigarettes and reduced it to 0.8 of a gram. Didn't tell the physician, didn't tell anybody. But he, okay. but anyway, he realized he was using the same amount and he just ran out sooner because they gave him less. They got that straightened out. But the asterisks there, when I go to, these are the 11 criteria. The tolerance or withdrawal, you don't count them. A physician is not to count them if the physician prescribed those medications. So if as a care provider, if I were a nurse practitioner and I put somebody on opiates and their life was kind of in shambles because of it, they got high tolerance to it, they would have severe withdrawal if I took it away, I don't count those symptoms because I recommended it, I prescribed it. But if a patient decides this is going to help me and they got it, then it's bad. So the criteria is screwy. This just gives you some comparative rates. This is an old rating, but they believe it today. Everybody uses it. Tobacco, 32% will become addicted who try tobacco. And we all know tobacco, it's a very tough drug to get off of. Heroin, about 23% who use it will become addicts, will become dependent on it. We go down to cannabis, 9%, and I will say people can get addicted to it. But I'll tell you, 9% is a high thing. Again, they're using the wrong criteria to put in it. They are going on with blinders, not acknowledging that a patient is actually using it for a health problem. As soon as they see someone using it daily, that's a negative. So we've got that mixed up. This is a rating by a guy from NIDA, the National Institute on Drug Abuse. And they were asked to rate these 6 drugs. The first one, dependence, was really more about addiction because withdrawal addressed the physical dependence. But if you can see, cannabis, lowest addiction rate, lower than caffeine. How many people can't start the day without their cup of coffee? You know, people really need that. They crave it. How withdrawal? Side effects lower than caffeine withdrawal. Tolerance slower than any of the other drugs. Reinforcement, yeah, people like it it's a little bit more reinforcing than caffeine. And yeah, intoxicating, it's more intoxicating than caffeine or tobacco, why people do choose to use it sometimes just to relax. It's a safe choice. When we look at treatment, we will never send somebody in for detox on cannabis. We're not going to get them they will never go in a hospital. Alcohol withdrawal, benzodiazepine withdrawal can be life-threatening. Very often they need to be in a hospital. Heroin withdrawal, oxycodone, all the opioids, may or may not go to hospital, but I tell you what, most patients think they're going to die going through withdrawal from opiates. Cannabis, not a problem. Treatment, they do have different treatments for patients. 2 things that are really funny, not funny, tragic, I guess. Rimonabant was a French drug. It was actually an antagonist to the cannabis receptor. So when it went in there, it would block the effects. And a lot of us thought, that's not a good idea. But they thought, oh, what a good drug it would be for weight reduction. Because if cannabis gives you the munchies, this would take away your appetite. So then they thought, well, if you have a cannabis addiction, we can give you Rimonabant. Well, what happened is as people started using it, depression set in, suicidal ideation. They took it off the market. Not a safe thing. Do not mess with your endocannabinoid system. Not good. Then the other thought is they thought, well, we can give those cannabis addicts, we can give them Marinol, like methadone for an opiate addict to put them on methadone maintenance, a safer drug than heroin, longer acting, keeps them kind of steady. So they thought, well, instead of smoking that pot, we won't give them this natural plant, this safe natural plant. We'll take out the psychoactive piece and we'll let them use that for treatment. It would be like the people in South America who chew the coca leaf and somebody's saying they've got an addiction and we'll give you here pure cocaine to treat your addiction to the coca leaf. It's crazy. So generally, if people do have a problem with it, they can get some kind of help and treatment, and there are support groups because AA and NA, Narcotics Anonymous, AA, some of the really well-established AA meetings get it. They actually can get people are using it as medicine. But for many of the patients going there, they're like, you're just substituting, you're using another drug. Come back when you're ready to quit that too. So there's there. So I'm wrapping up. The increase in treatment admissions, why? And they tout that all the time. There are so many addictions. Well, if you go for a job and you test positive, treatment or no job, you take that. If you get caught driving or something and you've got cannabis and THC in your system, jail, fine, or or treatment. They go into treatment. Any normal person would go into treatment. They might not have a problem, but they're not going to go to jail. Why go to jail? And again, the intensity of treatment is way low. It's not a big deal. So when we look at cannabis from a nursing perspective, when they use it with opioids for chronic pain, you use less opioids. It happens across the board. Patients get off those medications. So we call it opiate sparing. It can be used very well to help people get off. And that's why most addicts list cannabis as a drug they use. Sometimes they don't know it, but if they can't get heroin, cannabis will help them feel better. If you can't get alcohol, cannabis will take care of you until you can get your next drink. Until you get your next pill, whatever you're taking, it will help you with withdrawal. But the addictions, people think it's just another drug. We call it an exit drug, and again, it's been used just like methadone for heroin. It has been used with success as a substitute because it puts you back in balance where those drugs take you out of balance. Real quickly, I can't go into this, but there are a couple studies basically showing people in opiate treatment program using this naltrexone, which literally is kind of an antagonist to the other drugs, so they stop using it. They do better if they use cannabis as well. In a methadone clinic, those who use cannabis, not that it was legal, but they did a study in Philly, those who use cannabis during induction when they're trying to get the dose right for methadone, they did much better and stayed in treatment because cannabis helped them feel better until they got to the right dose. So all in all, this is a bad practice, the cannabis prohibition. We end up with healthcare professionals because of the intimidation. They don't even want to learn about the endocannabinoid system. They don't want to hear you tell them that cannabis helps. They actually refuse to treat patients. They've stopped paying prescriptions for patients. If you tested positive on that drug screen, you don't get any more opiates. They put somebody in withdrawal. That's malpractice. You look more and more, the whole idea is giving you a pill that has a lot of side effects before they try the safer drug, cannabis. From my perspective as a nurse, you want to try the least harmful first, so you should try cannabis. If it helps, great. If you need more help, they might have a medication. They've actually taken patients, legal cannabis patients, off transplant lists because of cannabis use. And these patients, that was the only thing keeping them alive until the transplant, and they just took their life source away, and we lost patients because of this. So think of cannabis, wide margin of safety. If you need something quick, you can smoke it or vaporize it because it will work like that. You take it in other forms when you want something more long-acting. But improves sleep, quells nausea and vomiting. It's an anti-inflammatory. As we get older, most of our diseases are because of inflammation. One way or another, something's going wrong in our body, and the inflammation causes harm. It decreases pain without the mental clouding. The patients aren't in a fog. They aren't going to fall down and hurt themselves. They can talk with their family at end of life. They are awake and with it. Decreases or eliminates other medications. Again, the more you add, the more dangerous it gets. It has a low risk of addiction compared to most of these drugs that are passed out readily. So I look at it as a harm reduction medication. Todd McAree is now deceased, but at the time he said we should be thinking of cannabis as a medicine first that happens to have some psychoactive effects, as many medications do, rather than as an intoxicant that may have a few therapeutic properties. So we need to do a complete reverse of how we look at this drug. The risk quickly, and I know I've got to get quick, but when we think of risk, it's the prohibition. They always talk, we can't have people smoking medicine, and most people who are in the industry say, well, we're not. We're telling them how to vaporize. We've got tinctures for them. We've got edibles. We've got topicals. There's transdermal patches that last for 12 hours for patients. But again, it's the prohibition. The fact of lack of quality control. Patients need it. Where do they get it? Is it safe? Is it grown safely? And do they know what's in that medicine? And if they find it works, can they go and get the same thing day after day, month after month, year after year? Or is it a whole different kind of cannabis and it doesn't work as well as the one before? the medical supervision. Because of these crazy laws, our hands are tied. It's a Schedule 1. I'm not supposed to touch it. The physicians are not supposed to touch it. We make the recommendation, and you're on your own. Good luck. Wish you well, but go find it. And the legal consequences. So I end with the fact that the legal consequences are serious. The veterans, they fear what happens getting kicked out of the VA if they're using it. But we have people, I put up the cartoon, I think that says it better. The SWAT team's coming into the house. This happens. It's not a joke. People have been killed because wrong house. Whoops. And somebody's just trying to defend themselves when cops bust through their door. They easily killed the pets right in front of kids. They had shot their family pet and let it bleed to death while dad's put in handcuffs and the kids are told to sit on a couch with a gun pointed at them. The prohibition is really harmful. So thank you for your time. And I just want to say, trust me, I'm a nurse. I'm not gonna lie.
All right, one more time, big round of applause, ladies and gentlemen, for Mary Lynn Mathre. Very educational.